So Swamijit and Shankar, I would request you to start. You are muted, Swamijit.
Good evening.
Good. Uh-huh.
It's a
Carry
distinct
on.
pleasure for me and a private privilege to start this webinar. As you know that a couple of years back we had started this study groups of ASSI. At this point in time, we have three study groups: one on enabling technology, one on pediatric deformity, and the other on infection. And the chairpersons of each of them have been kind enough to formulate a academic program throughout the year. While the study group on pediatric deformities have just concluded a scoliosis week at Ahmedabad, with the good offices of Dr. Menon and Dr. Amit Jhala being the key person who organized it. It was followed by a couple of webinars on infection, and Dr. Raj Shekharan, who was the chairperson for the infection study group, has a couple of webinars organized, one on TB spine and the other on surgical site infection. And I've had a couple of interactions with Dr. Chabra in enabling us to formulate the academic year for this study group, and he's been so kind to start off with these two webinars. And uh, today we have the first webinar of the Enabling Technology Study Group in ASSI. Without wasting any more time, I would ask Dr. Chabra to please take over.
Thank you, Dr. Swamijit and Dr. Shankaracharya. With your permission, now we will start the webinar. I hope you are able to see the screen.
Yes.
Yeah. So, welcome to the webinars on Robotics 2.0, precision learning curves and real world outcomes. I'll be delivering the opening context and objectives to the webinar. As you are aware, over the last 2 decades, spine surgery has moved rapidly from novelty to mainstream, and in some centers almost to expectations. But as adoption has increased, so has variation. Variation in outcomes, training, value delivered. Uh, Early spine robotics, as you are aware, focused on pedicle screw trajectory guidance, static execution of pre-planned paths, accuracy as the primary endpoint, and robo as an adjunct to the surgeon. And of course, there were limitations: narrow clinical scope, workflow disruption, benefits largely limited to instrumentation accuracy, and minimal impact on broader care pathways. So there has been a conceptual shift from robotics 1.0 to robotics 2.0. Uh, when many of us first encountered spine robotics, as we discussed, it was largely synonymous with pedicle screw placement. But robotics 2.0 goes beyond that. It represents a shift from robo-assisted surgery to robo-integrated spine care, from tool-based accuracy to system-level intelligence. So, uh, the core pillars of Robotics 2.0 are preoperative planning integrated with intraoperative execution, workflow optimization, standardization across surgeon experience levels, team-based adoption, not surgeon-only use. In other words, the robo is no longer just a tool, it becomes part of the system of care. So the objectives of this webinar are: does robotics truly improve precision? And if so, in what situations does that precision actually matter clinically? How steep is the learning curve in real world practice? What outcomes actually change for patients, surgeons, and hospital? Does robotics truly improve precision, and when does that precision matter? What we know from evidence is that multiple studies demonstrate higher pedicle screw accuracy with robotic assistance compared to freehand techniques. Meta-analysis report accuracy rates of 95 to 99% for robotic systems versus 85 to 90% for conventional freehand placement. What remains nuanced is improved accuracy does not automatically translate into better clinical outcomes for all patients. The clinical relevance of precision is highest in complex scenarios: deformity, revision surgery, dysplastic or osteoporotic pedicles, and MIS multi-level constructs. Uh, how steep is the learning curve in real world practice? What the literature shows is that most studies demonstrate a learning curve of approximately 20 to 40 cases for workflow efficiency, setup time, and planning confidence. Early adoption phases are associated with longer operative times, which normalize with experience. The real world considerations are that learning curves are system dependent, not just surgeon dependent. Factors influencing outcomes also include OT staff familiarity, imaging workflow, case volume consistency, and bailout training. When outcomes actually change for the patients, surgeons, and hospitals, when it comes to patient level outcomes, there is strong evidence that there is reduced screw malposition, comparable or reduced complication rates. However, there is limited or evolving evidence of long term functional outcomes, fusion rates, and adjacent segment disease. When it comes to surgeon level outcomes, there are consistent findings of reduced radiation exposure to surgeon and OT staff, reduced physical and cognitive fatigue in complex cases. Surgeon safety and sustainability are underappreciated but real benefits of robotics. And when it comes to hospital level outcomes, evidence suggests our ROI is volume dependent. Cost effectiveness improves in high volume centers, complex case mixes, shorter length of stay environments. So the robotics creates value only when embedded in a structured program, not as a standalone purchase. Friends, we will be discussing this and much more in the next 85 minutes or so, when we will have a wide range of people from a wide range of institutions discussing on this very important topic. And I would in fact want to invite our next speaker, Dr. Vidyadhar, or I leave it on to the moderators to invite him to do so. But friends, before I stop this introduction to this webinar, I would request you to join us again next Saturday at the same time for the next in the series of webinars. And this webinar, friends, is also going to be very exciting on robotics versus navigation. Is there incremental value in pedicle screw fixation and beyond? So over to you, Soumyajit, for the remaining part of the webinar. Please moderate the webinar. Thank you.
Thanks, Dr. Chabra, for this nice introduction to the next few hours. Dr. Vidyadhar is very well known across the length and breadth of the country because he has been a pioneer in robotics in this part of the world, and he's a senior consultant in Manipal Hospital, the Manipal Institute of Robotic Spine Surgery, as it is now called. And he's, I think, the single person who has done the maximum amount of robotic surgeries in the minimal time. Once upon a time, Medtronics used to show his caliber across the length and breadth of the world because within the first few days, he has done the first 50 cases in robotics, which nobody could parallel themselves. So over to you, Vidyadhar, for the next few minutes to have your talk on precision beyond accuracy.
Thank you, sir. Thank you, Chabra sir and Soumyajit sir. Am I visible? My slides are seen?
Yes, sir.
Yeah. So I'll directly go on to the, what is this?
Slideshow.
I think slide is not seen, right?
The slide is not.
Sir, we can see, sir.
Where you can see now?
Yes, sir.
Okay. Good evening, friends. Thank you to ASSI for the invitation to speak in the Emerging Technology Session 2.0, the webinar. Today, I don't want to show how robots work. We all know that. Instead, I want to ask a more uncomfortable question. If our reported pedicle screw accuracy is already 95 to 98%, what exactly are the robots adding? A little background to the talk. We
Can you
started
go to
robotic.
slideshow, please?
Oh, is it seen?
It was, yes, that's fine. That's fine. Go ahead.
Now?
Yes, sir.
MIRSS is one of the fastest evolving robotic spine centers globally. We published data confirming safety and precision in over 18 publications in peer-reviewed journals. Our work provides a unique Indian perspective, high volume, complex pathology, and cost-conscious ecosystem. Over the decades, we have moved from open surgery to minimal invasive, navigated, and robotics. But surgical indications, principles, and decision making have remained the same. What has changed is the execution fidelity. Robotics improves how reliably we execute what we already believe is correct. My argument today is that robotics does not primarily about accuracy, it's about precision, reproducibility, and consistency of execution, especially in complex spine surgeries. I'll keep it short. Robotics converts anatomy into a plannable 3D digital model with various tools for planning, allows trajectory planning before any incision, and then robotic arm physically guides execution. The key difference is not visualization, it's plan adherence. The robot doesn't think, but it doesn't drift either. Freehand surgery relies on mental imagination of the 3D anatomy from the 2D images or landmarks. Robotics externalizes the cognitive load onto shared digital plan. This means the plan is visible, reproducible, and teachable, not locked inside one surgeon's mind. Accuracy means hitting the target once. Precision means hitting the same target every single time. In spine surgery, as we all know, especially deformity and long constructs, we are not placing one screw, we are placing 20, 40, and sometimes 50 screws. One deviation can change biomechanics, neurological risk, and revision rates. Robotics fundamentally addresses scatter, not just target hit. When we discuss robotics, the conversation usually stops at accuracy numbers. We know from literature accuracy with freehand is about 95%, with fluoro and navigation 97%, and with robotics 99%. The problem is averages hide failures. Patients don't suffer from averages, they suffer from outliers. So the real question is not how accurate is it in given number of times. The real question is how consistently accurate is it across the surgeons or cases or anatomy. Our own data comparing three techniques too confirmed similar accuracies. The difference was 1.64 percentage points between the worst and the best. Don't get me wrong, this is statistically significant, but clinically, we are all accurate. Meta-analysis confirms this that all modern techniques exceed 97% accuracy. So if we were all hitting the target, what's the point? This is where we need to shift our thinking. We need to stop asking, does robotic make screws more accurate? We need to start asking, what does robotics enable us to do we couldn't do safely before? Robotics is equal to consistency, safety, and capability. The goal is raising the safety floor. It's about what you can do with confidence. Variability is introduced by many factors like surgeon fatigue, anatomy distortion, obesity, deformity, revisions, and even radiation limitations. Even highly experienced surgeons are not immune to variability. Robotics is not about replacing expertise, it's about buffering human variability. In engineering terms, it's variance reduction system. As execution variability decreases, unexpected revisions and complications fall. In our prospective comparison of freehand, fluoroscopic, and robotic techniques involving over 3,500 screws, the robotic accuracy was the highest. More importantly, accuracy did not depend on the surgeon's experience or even timing of the day. This is a crucial shift. Robotics acts as an experience equalizer, especially relevant in heterogeneous training environments like India. Experience neutralization means outcomes are less surgeon dependent. This improves safety, enables delegation, shortens training curves, and allows scalable quality. This is why robotics should be viewed as a system level intervention, not just a technical tool. One common criticism is that robotics has a steep learning curve. Our data across 750 cases shows accuracy was consistently more than 99% from our early cases across surgeons with different experience levels. Learning curve is for the workflow, not for the safety or precision of the robot. This is particularly important for young surgeons. We compared pin-based and pinless registration techniques and found equivalent accuracy of 99%. However, Pinless registration streamlined deformity surgery by eliminating trajectory obstruction, simplifying workflow, and reducing the operative friction. True precision lies not in screw placement, but in the workflow reliability. The benefit of robotics increases as anatomy becomes more complex, like severe deformity, dysplastic pedicles, revisions. This is opposite of freehand surgery where complexity increases risk. Robotics converts complexity into geometry. Few examples like these where freehand becomes too risky. First case, neurofibromatosis with 110-degree cervicothoracic curve. Second case, 168-degree thoracic curve with rib crowding. Even the robotic trajectories were blocked by the rib hump. Third case of 105-degree kyphosis requiring vertebral column resection. These cases, robotics doesn't improve accuracy, it makes surgery feasible. Revision surgery, this is where robotics shines the brightest. Broken S1 screws, like in the first case, robot visualizes the buried metal, plans new trajectory. Cement in the vertebrae, where navigating through the native bone, avoiding the cement is possible. Patient with a 147-degree curve, broken rods 3 times, robot navigates through the fusion mass at the apex to add rescue screws. When anatomical map is destroyed, robotics creates a new GPS. This revision series of ours of 64 patients shows clear learning curve benefit, robot time reduced from 20 to 16.7 minutes. Robotics is moving beyond pedicle screws for kyphoplasty, cement augmented screws, sacroplasties, osteotomies, S2LR iliac screws, and even iliosacral screws. Here, precision affects cement containment, correction control, and complication avoidance. This is the direction of future automation. Cervical spine offer almost no margin of error. In our large cervical robotic series, we demonstrated safe, reproducible trajectories across occiput to subaxial levels. Robotics gives surgeons confidence to expand indications without compromising safety. We can use the reliability of the robot to accurately and safely perform cervical spine surgeries, although the instruments and robotic software lacks the support for this region still. We started operating cervical spine with mixing and matching of lumbar MIS instruments with robotic arm to execute cervical spine safely. Although faced challenges initially, over a course developed our own novel workflow as shown in the video here. We also published this technique, and this is quite an inexpensive innovation which allowed us to safely use robotics precision and consistency in this challenging region. Next, this led on to more advanced workflow with custom instruments for Medtronic Vertex system, J-on Atlas, and our indigenous implant SpineVidya C-Tech system. Presently, we have devised a C-Tech system with the power of full instrumentation through robotic arm into the cervicothoracic junction. It has a 4 mm pedicle screw for cervical spine, 5.5 and 6.5 mm thoracic spine pedicle screws, and a single 5 mm diameter rod for cervicothoracic deformity correction surgeries. Next, S2ALR iliac screws and iliosacral screws involve deep, non-intuitive corridors. Robotics allows intraosseous planning with reduced radiation and high reproducibility even in revision cases. This is precision where fluoroscopy struggles most. S2AI screws we have used in 58 total so far, 100% accuracy, 0 breaches. We even do this S2LR iliac group fixation percutaneously through a single midline incision. The complex corridors have been made routine using robotics. Beyond accuracy, robot also improves safety for the surgeon, such as radiation, fatigue, posture, ergonomics. An example is shown here from our center's published data, 17% reduction in radiation per case. Do the math, 100 kyphoplasties per year. For 20 years, you save nearly 8,000 milligrays over your career. For you, your techs, your anesthesia time, this matters. Robotics reduces variability, improves reproducibility, neutralizes experience gaps, and enables scalable precision. Accuracy is just one measure of outcome. Precision is the true clinical advantage. Robotics does not choose indications, it does not replace judgment, and it cannot compensate for poor planning. Technology amplifies intent, good or bad. Responsible adoption is essential. India has a wide variability in training exposure, high complexity of cases, and workforce shortages. Robotics should not be viewed as a luxury, it is a quality equalizer. If adopted thoughtfully, it can raise the baseline standard of care. Accuracy is a number, precision is a system, reproducibility is the endpoint. Robotics enables all three when used responsibly. I would like to take a moment to thank my team for all the support and involvement without which what all that I spoke would not have been possible. And I would also want to thank Manipal management for supporting me in pursuing my dream to the point that I am living a dream being realized. Thank you, ASSI, for the invitation for and to all the surgeons sitting through my presentation of our honest experience and learnings with robotics. Thank you, one and all.
Thank you, Vidya. Can we just stop sharing your screen, please?
Yes, sir.
I would invite, thanks for your talk. We'll take the questions at the end. Dr. Shankar, can you please introduce the next two speakers, Dr. Gururaj
Hi.
and Dr.
Can you
Bharat.
hear me? I think
Yes.
next talk is Guru's talk. Dr. Guru Raj is Chief Consultant of Spine Surgery in Indian Spinal Injury Centers, Vasant Kunj. They have a navigation and a robot for many years, and he has an vast experience on doing robotic and navigation surgery. May I request Guru to give his talk now, please? Guru, are you online?
Sir, he's at the airport. He requested me to play the PPT. So I'm going to play, sir.
Okay, okay.
Should I start, sir?
Yes.
Yeah, please.
At the outset, myself, Dr. Gururaj Sanmandimat, I would like to thank ASSI and Dr. Chabra for giving me this opportunity. Today, I have a tough job of critiquing a well-established technology, a well-established procedure. It's like critiquing a hit, popular, well-made movie, which has already has who is popular among critics, but then I have to go against the tide and critique the this advanced technology. So let's try to understand the real world challenges and limitations and outcomes of robotic spinal surgeries. Why do we need this advanced technology? Or why do we need any new technology? That is to reduce complications. So as in these days, like increase in the number of spinal surgeries being done throughout the world, there has been increase in complications and revision rates. So we are trying to reduce these complications and revision rates by using spinal robots. So what these robots or these brochures of these robots do promise, that is, they promise higher precision and accuracy, which is actually they are known for and which is actually a reality. They do promise faster recovery. They do promise reduced surgical timing and hospital stay. They do promise reduced complications. They do promise reduced radiation. They do promise reduced revision rates. And they do say that it's a revolutionary technology which revolutionizes spinal care. Is that so? We will see in coming slides. The crux of any procedure or new technology depends on the clinical effectiveness. But then we all know that clinical effectiveness not only depends on the technology which you are going to use, it highly depends on the surgeon and surgeon's experience, patient condition and patient's pathology, or hospital overall infrastructure. And we all know that robot doesn't replace human judgment and skills. It only assists your skill and your judgment. It doesn't guarantee, if it's not well done, success in all cases. And some studies in literature also show that contradicting results, or they say that there are similar outcomes as compared to conventional treatment. Again, we know that any success of a new technology or a procedure depends on your training and the learning curve. Without that, every technology will go into disrepute. How, what brochure promises that it promises that with the good training, you can have a flawless 45 minutes procedure, zero complications, effortless system integration, and immediate cost savings from the beginning. But is that so? No. Initial cases might take more than your conventional surgeries. You will encounter unexpected technical difficulties. There will be workflow bottlenecks because your entire team is not geared up. Sometimes you might have to convert these surgeries to open surgeries. Cost saving, is that a reality? Is a debatable thing, which we will see in coming slides. In terms of training and learning curve of surgeon and surgeon team, it's an ongoing process, but it is limited by limited number of good training centers available. And if you don't execute, robotic surgery is not always error-free or errorless. You have to follow protocols. You have to understand spinal robots are delicate. You have to identify where you can go wrong, and you have to train your team. So this takes time, and it's a time-consuming process. Robots brochures don't tell you that you require a supervised training for initial 20 to 40 cases to identify all the niggles. And you have to spend extra hours in your OR and outside the OR in training to execute these surgeries successfully. In initial few cases, it might take more time than the conventional cases because of team is not trained enough, workflow adaptability is not there, planning on the console takes time. There is increased operational complexity because these robots occupy space. You have to have a bigger worms, bigger work operation theaters. You have to have a supplementary equipment. You have to have a compatible table. And initial few cases frustratingly take more time in setting up the robot, draping the robot, calibrating, planning, acquiring images makes you frustrated when you have a high workload with you for the day. And then you require a very good team coordination amongst from the technician to your assistant surgeons to anesthetists to robot technician to your sisters. You require a good coordination. So that disrupts basically your theater workflow, which is already established, because you have to establish the new workflow there. In spite of all this, there can be human errors in setting up. You have to have a updated software. You can have calibration issues. So because of all this, it is being found that in initial few cases, your complication rates actually can go high to the tune of 25%. If you're not convinced enough, if you're not, if your conviction is not enough to succeed with robot, then you might end up giving up this technology for good. Also, it has got executional challenges. I vouch this is good for MIS surgeries, but in open surgeries, it has got its own challenges. To execute the ideal trajectories which you have planned, your soft tissue pressure doesn't allow, it skives medially, and you might require extra incisions on the side for executing a seamless robotic workflow. Especially in scoliosis and deformity cases where your rotation is more than grade 2, because your instruments come from far off, you have to have extra incisions and also your rib cage might come in between your trajectories. And we all know that till now, there is no approved protocol for, or it's not approved for cervical pedicle screws, even though some of us have used and we have burnt our fingers. But with time, we have been successful also to execute cervical pedicle screws. Then patients tend to expect more when you tell them that you're going to do a robotic surgery. They think robot will perform the surgery accurately with precision, and the next day they start dancing around. That's not the reality. Robot doesn't guarantee you full recovery, zero complications. Robot doesn't complete the surgery. It is you and your team which is going to make the procedure successful. So patients' expectations have to be kept to realistic. Next, any technology does have this unholy alliance with the cost. The costs are exuberant. There are upfront costs of purchase. There are huge costs for maintenance. And sometimes the software updates also cost equally. So it's only feasible in large hospitals with high workload where you can justify and make it cost effective. And it's only possible in urban or high income regions. Prohibitive in developing regions. But on the contrary, actually the robots and technology should supplement to the lower skill levels in developing regions rather than in a developed regions. But then the cost prohibit these robots reaching these regions. And then we have these ethical concerns because of overconfidence in technology. You tend to overmarket and sell it to the patients. Patients have overconfidence on robots and ultimately leads to dissatisfaction. This widens the healthcare inequality between developed and developing regions. When you have invested so much, you tend to prioritize profit over patient benefit. So, to negate all this, ultimately you require a transparent communication to set a realistic expectations out of any new technology like robot. So, in summary, what or when it works, the spinal robots, when you have complex multi-level fusions, especially when you're doing it through MIS approach, in revision surgeries where anatomy is altered, in challenging anatomic cases like deformity, the success factor is not the technology, it's the surgeon and surgeon team which is committed and goes through those frustrated initial few cases and champions the workflow. You have to be ready to train yourself and train your team and invest that time. And the realistic case selection is the crux here. Next, what are the measurable benefits you already know of? That is right now we know that it definitely reduces radiation exposure to yourself and your team. It has got a greater placement of pedicle screws, or it has got a more precision as compared to a conventional freehand method or a 2D based image intensifier. It will enhance your confidence in complicated cases. But these things can be delivered only when you are well trained, and very few people who have championed the protocols and the workflow will deliver those promises which are mentioned in the brochure. Everyone is not able to deliver those brochure promises. So it requires more training, more research, and more investment of time. And we all should understand that patient satisfaction doesn't really correlate with the technology of choice, but it is you, surgeon, and its team's skill is the primary factor which contributes to clinical success. Thank you.
Thank you, Guru, for this excellent talk. This opens up to new perspectives. One which Vidyadhar showed how doing complex robotic surgery and large volume of surgery is possible in a high-end center. And then you brought out some drawbacks and some challenges which robotic surgery has. However, I think Bharat Dave is the next speaker, and he is the owner and head of Stavia Hospital, which is high-tech hospital and low cost. I think he's got all the gadgets and he's the gadget king of India. And he believes in technology and believes in good outcome and also precision surgery with low cost. And I'm sure he is going to refute a lot of what you said, and we will have a healthy discussion at the end of it. Now, can I request Bharat to start his talk, please?
Thank you. Yeah. Thanks, Dr. Chabra and the moderators, Dr. Soumyajit and Dr. Acharya. Lot has been said by all the three previous speakers, and I'm just going to talk over the same few more points to add. This talk was made by Mirant, who is doing the robotic surgery at Savia. So we have learned about the accuracy, how it is enhanced by Dr. Vidya's talk, and which was sort of addressed differently by Dr. Guru. So is the data in the literature reliable? Well, we know that the information can have its own pros and cons, which we can dig out, like the previous two talks, Dr. Guru and Dr. Vidyadhar, both the talks were completely contradicting as well. Why so? Because it's human to happen. We can have human being contradicting each other, but technological integration is must, and that has to come. And can we change that technology integration? No. Perhaps we can improve, and can we make it to 100%? Perhaps not that either. But Almighty also makes a mistake. So we really need to be ready for those mistakes which Almighty has made. And that's where we all believe in the Murphy's Law, and we should have the 1, 2, 3, 4 ready for any situation that we overcome on table and with our patients to give them the best. So real world outcome encompasses significant range of factors, and we really need to have the collaboration with the nurse and surgeon and overall recovery experience. But we should have the beyond technical precision, effective patient outcome reflects more than just that precision, and which Dr. Vidyadhar and Dr. Guru has mentioned in their talk as well. So can we make this unpredictable predictable? That is the whole essence of the talk, or that is something which we should be really looking at. Can we make it predictable? Well, it's not possible because there are so many variables. And as we know that 1950 the pedicle screw started, 2004 robotics started, but then we have so many new things coming up in the same as well. So my talk is regarding changes with the patient and changes with the hospital. So let me talk about the perspective what patient expects. It has enhanced quality of life, faster recovery, and as Dr. Guru mentioned, sometimes the patient also knows that this is something which is done by the robot. I'll come to that in next slide. But in the real time, accuracy is certainly enhanced. There are n number of paper and publication, but the amount of the screw matters the most, because that is where we really are worried that we are charging lot more, or we have to collect more money from the patient because of the same, because the screw trajectory is screw compatibility, and we have to make like what Dr. Vidyadhar has made, their own trajectory and jugaad. We probably are going to have the match-opening patient will have the match-opening. Oh, my surgery is done by robot. That is something which we really need to make them understand as well. And I have undergone the best. Why am I not getting the result? And that is something which is this case as well. We had the double pathology, and which was done by the robotic surgery. We had the excellent correction with the wage resection as well. So Murphy is there all the time, and expectation increases and does not match with the reality. That is the robotic surgery too. So many misperceptions still prevails among the general population. 75% of this patient-based data shows that 75% believe that the robotic surgery is faster, and 20% of them, they said that robot is doing the surgery. So we really need patient education before discussing the robotic surgery as well. This is very important, particularly for the spine surgery. So robotic assisted surgery demonstrated steady increase. The global market has increased as well from 26 million to 2.77 billion in 2022. So that is significant rise as well. And we really need to move with the same rise as well. But what changes with the hospital? The perspective, marketing cost, enhance reputation, because then you start having the reputation that, oh, this guy has got the robot. Patient attraction is also, and FOMO, fear of missing out. This is something which we have observed over the period, that we really feel that, okay, we really need to have the robot. Real time and theater issues, this is very important to address. Operational efficiency has to be must. We have to have the financial implication. If you start looking at the ROI, you probably won't be able to buy any of this gadget. Interdisciplinary collaboration is must, because that is something which is very important. We really need to have the anesthetists working in line with our thing, because the IUNM is done, and then if there is movement, then the robotic accuracy will be lost. Training of the surgeon matters the most, as Dr. Vidyadhar said, but I would like to differ here, and I would like to walk with Guru that yes, training of the surgeon matters the most as well. And perhaps in the coming days, the curriculum should be included in the training part as well. Changes for the hospital OT need, surgeon familiarity, avoid skiving. This has been discussed between me and Dr. Chabra, and we have had issues related to that as well. But fortunately, at our center, skiving has not been an issue. Staff consistency and training is utmost important, and really need for maintenance is something which is very important. As mentioned, the OT needs adaptability, table mount, floor mount, all that matters the most as well. IUNM, when we are doing the IUNM, the consistency has to be with the anesthetists, and drip and reflector are again a challenge, and the OT need for robotic surgery too. So training 40-minute initially we started, now we are able to do it in the 4-minute. Training the assistant, which is very important. Somebody who does not know, if you have a new assistant, you do not want him or her to scrub with you, because that is something which can reflect in the surgical field as well. The most important, accuracy will get compromised. Dexterity is the most important part, because that is something which we really need to concentrate on. Follow each OT need and jugaad to set. It takes time, as Dr. Guru mentioned as well. So outcome with the robotic spine surgery, positive outcome, enhanced precision, reduced blood loss, complication, shorter recovery time. All this has been written in the literature and number of the time, improved satisfaction and lower reoperation rate. Negative is what? High initial cost, as mentioned earlier. Steeper learning curve. I would say that at least 15 to 20 surgeries is a learning curve for robotic surgery as well. Limited availability of technology, potential device malfunction that often is observed with the current robotic table mount robotic which we have, and patient concerns and anxiety has to be addressed well in advance, in order to make sure that, because there are literature, they keep coming in the newspaper as well, that this robot has burned someone's intestine and this and that, and so that's why patient sometimes goes away from robotic surgery too. So real world call for impact. Are surgeries inaccurate with robot? Certainly not. It adds not only accuracy, but it adds a positive feeling to the patient and hospital. This is what we have observed at Savia. Operational efficiency, reputation, and financial benefit has to be considered and has to be balanced. Big tool for elite class, positive impact to life and surgery, and hospital performance certainly adds on as well. Has Savia achieved all this? We have not marketed as much as we wanted to, but yes, it has certainly some impact as well. Meaningful outcome has improved. What truly matters the most in this robotic surgery at Savia. Floor mount and table mount have different challenges. I repeat now, these are virtual images, and these virtual images has to be confirmed by second spin for accuracy and position check. That is what we believe at Savia. So we most of the time go for the second spin in most of the cases as well. And breakdown has been an issue. Tech dependence, staff dependent, assistant dependent, accuracy multiple checks, that also takes time as well. So many articles you will find about the accuracy in the literature. This is something which we have done in our study, and overlapping done human measurement error was practically zero, and we had this entry point deviation average 2.27. So these are the cases, these are the screws where we had done the planning, and then after the second spin was done and there was overlap, and this was found in our study that there was 2.27 deviation. There was one 3.7 degree angular deviation, and lateral angulation, angular deviation was 0.4 degree as well. So it's something which is not that much and probably perhaps won't reflect into the clinical scenario either. Surgical time, 98 surgery. So you can see that per screw, initially it was 5 surgery, 13 minutes. Now in the last 5 surgery, it is 5 minutes. The spikes that you can see here, it's because of the degenerative scoliosis cases which were done as well. But at the end, the overall time is only 14-minute difference in this surgical group as well. So this is something which we have observed at Savia, and this is our data. So, in conclusion, many articles published by Dr. Vidyadhar and literature, current favors robotic continues to evolve. There is less radiation, but we really need to have the standardization of procedure. Post-op outcome rehab substantially enhanced with the robotic use, but still, what matters is the archer than the arrow. I repeat, the surgeon who is doing must have the tactile feeling and must do the surgery with lot of precision. Lot of input has to be given, so it is surgeon who leads the robot rather than the robot leading the surgeon. So archer is more important than the arrow. Whatever you do, it is the destiny. Well, we do not believe in that. We believe in making the destiny. This is what something which we believe in Savi as well. So like this was, the croco. You cannot put your head into that, but that was something which was the show as well going on. Similarly, nothing is foolproof. Anything can happen to anybody tomorrow. So older and experienced you become, more you choose calm over the chaos, distance over the disrespect, drama becomes intolerable to you, and peace becomes the ultimate priority. So that is what gets added. You start surrounding yourself with the gadgets that gives you and your patient peace. Precision requires more for the mental health, heart and soul for ourselves and our patient, and that is where we have this integrated operation theater spine suit. All the gadgets are integrated in such a way, including bone scalpel and IUNM. So we give and get the best to our patient, and that is where the technology plays a major role, and that's what we have found. So surgery is a marriage, cannot divorce, hence we really need to optimize to enhance the safety, and that is severe. Thank you very much for giving me the opportunity. Thanks.
Thanks, Bharat. Can I request Dr. Chabra to introduce Josh Schroeder?
Yeah, thank you, Somajit. I think introducing Josh Schroeder is like uh, uh, introducing people to Jesus Christ or Ram, right? Because Ramji, because Josh Schroeder was involved with the development of the robo, which we are using globally now. He has a huge wealth of experience, and I think it is our pleasure and honor to have him with us today to be talking to us about his experience. But we thought what would be very important in gaining from his experience is his thoughts on where we are proceeding, right? Robotics 2.0, what's coming next is what Josh will be talking about. So over to you, Josh Schroeder. And we
Thank
are
you.
privileged to have you with us for this webinar today. Thank you.
Thank you very much. I hope you can hear me fine and see my
Yep,
screen.
we can hear you
So,
fine. Right.
so first of all, I would like to welcome you to come and visit us in the city of Jerusalem. We're not just a history of the past, we're the city of the future as well, a fast-growing startup nation and a close friend to India. And whenever you want to come, guys, please just email me. I'll be more than happy to host you. These are my disclosures. And in the next few minutes, I'll talk about the needs, what's happening today a little bit, to try to not talk again about what my colleagues talked about as well, and what is going to happen in the future. So, I mean, these slides have not been changed, and unfortunately, we see too many of them still today. And as we all agree that over the last 20 years of the revolution of spine surgery, we should not see any of the screws going inside the canal, but unfortunately, we get these cases referred to us, we see them coming around, and we know that technology is here to be. We know as well that the screw misplacement is high. It's between 1 to 10%. And we know that even if for the Gerbstein-Robbins criteria is very forgiving in the sense that it will allow us under 2 millimeter breach, but sometimes 2 millimeters is quite significant. Surgeon's experience, level of the spine, the deformity, the revision surgery are the factors that misplace us. And we know that it also causes nerve damage, and that needs to be considered whenever we're doing these kinds of surgeries. Now, what are robotics today? In robotics today are every part of our everyday life. I mean, we do drive our car with our robotic cars today. We use them to clean our houses. We drive footballs. We have our packages sent over, and we know that robots are very, very good. We're in the previous generation up to the last maybe year or two. Robots are very good at doing the same thing every time. When you have an assembly line of a BMW, like you can see over here, that everything is done in a meticulous way, and every time things are prepared in the same manner. It is the same here that you can see in the designing of these new microchips that are coming out of Taiwan and out of Israel, which have the, excuse me, the atomic level precision that robots can do. Now, if robots can do such good jobs on these very, very small structures, where are we at in our spinal world? In the spine room, I'd say the leading robot in accuracy today is the Da Vinci robot with the new generation. And I can show you how that can be also integrated into a spine work over than the Mazer that we've been using. So as I mentioned beforehand, robots are very good at doing the same thing every time with accuracy and mistakes. They help us executing instructions, they execute them at the same times. They reduce human work, as mentioned here very nicely before. They can help us take off a lot of the boring stuff. You know, many things that are meticulous. If you're doing a big case, it can help reduce the workload that we're doing on, and they don't complain. And as we all like, everyone likes gadgets, and they're cool for us to have. They're not good at designing for themselves. They can't think for themselves today. They can only do what they're planned to do. At times, they can provide us with a false safety feeling. They're not good at a changing environment, which is very predictable in our spine surgery, and I'll mention in just in a bit. And they might make humans over-reliant on robotic help. And many times when the robots break down and when the robots break down and we have a problem, we still need to go to plan B. And I can show you a case of that we had just this week, which we did. In medicine, we're entering the AI world. We know that AI is helping us reading imaging. We just did a very big study looking at human versus radiological imaging of vertebral fractures. And we found that out of 3,000 images, radiologists missed 80 fractures. These fractures were picked up by AI with automatic readers. Does it do an overdiagnosis? Is it perfect? We know the answer is not yet. AI helps us analyzing results. There's a nice study just that came out about colonoscopies, looking at them and trying to predict data, helping us with diagnostic. And also today's world, we've been seeing these machines that are coming out of China. They're talking about how to help us establish care. Are we there yet? No. We're still in the 80% spectrum, but it's coming down our alley, and it's something that we have to deal with as we're moving on ahead with medicine. Thank God, I've been privileged to deal with robotics since the first generation, 2004, and we've been using it over the years, and now we're using the last generation, which came out in 2019, and hopefully we'll be moving on to the next generation of robotics in the next year as well. And I can talk a little bit about it. I cannot expose the next robot yet, which is coming out, but I can talk about what we're moving to. There have been several other robots on the screen and the platform, and we know that robotics is being a more and more accurate part of our life. In today's world surgery, we preoperatively plan or take an intraoperative imaging. We do our planning. We try to merge our work with our plan work, and we have our extra intraoperative execution. For example, in the 67-year-old lady who had a very large surgery done many years ago, you can see the Harrington rods inside for a spinal deformity, and there's really very little anatomy left there. She has bad pain and claudication and field conservative care. Where do we place our screws? With this huge bony islands above, the whole place is full of bone. With the robotic planning, we can plan our screws, execute them accordingly, take our shots, execute, get everything done, fuse her down to the bottom, and hopefully send her home within a couple of days with very little complications. So, are robotics better than freehand? And we need to challenge that in 3 areas: MIS and PERC, revision surgery, open surgery, for lumbar surgery, regular and deformity surgery. Radiation, we've shown already 10 years ago that it helps us reduce radiation. I was very happy to see that these studies have been echoed in newer studies and followed up, that really robotics help us dramatically reduce our own surgery. In today's world, we're doing a percutaneous case, we'll take 2 to 3 shots for robotic acquisition, and then later on, we'll take a few shots just to make sure rods are in place. We've reduced our radiation exposure dramatically versus freehand and open technique. Accuracy levels have been published by industry-based studies. I'd say if we look at all the studies, over 95% of the studies published today in any one of the robots out there have shown very, very high accuracy rate. And people that are more familiar with the robotic world know that many of these studies, many of these robots, despite having a 90+% accuracy, are not anymore in the market, because when they were taken away from the industry and placed to real life, had a much lower accuracy rate. This is the truth, that everything needs to be taken with a grain of salt, and we know that things need to be done. In our hands in Hadassah, we've been over 10,000 trajectories done so far. We've reached a 95% execution rate. Our accuracy was and is still around the 93% rate. We've had several cases of neurological deficits despite robotic surgery. And we know that these cases are there, and we know that we need to watch it out, and we need to make sure that if things don't work correctly, we do it in our own hands. Still, taking this kind of case of a child with PJK with a deformed canal, with a 0 size pedicle, we're working between doing an in-out and screw adjacent to a deformed canal. I think we all would like some kind of assistance to do it. Now, I had a conversation with one of my colleagues last week, said, I can do this with navigation. And I said, you 100% can do this with navigation freehand as well. But where's your hand go? And with the robotics, it brings you a safe corridor, which helps us provide the safety throughout the case, and we don't need to worry about it misleading us. So I think we've seen over the last several years that MIS PERC robotics has a favor, revision surgery for sure, and also for open lumbar and deformity surgeries, we use it as a routine in every one of our cases here. So what's in the future? It's very hard to predict the future, and I definitely have not had the ability to have the ball, the future, telling you exactly what's going to happen. But let's talk a little bit about the trends going on today. So when we look at where we're looking at where the robotic world is taking us in the clinical world, we're talking about a new generation of robotics that will allow us to reduce the levels of accuracy to a sub-millimeter range. We talked today about robotics today, and if you look at any one of the pamphlets or any one of the FDA approval, they're between 1 to 3 millimeter accuracy, and that's not good enough for our work. We're talking about creating a digital twin, in which the robot will be the digital twin of the surgeon, allowing the surgeon to take a further step back. We're talking about screens with mixed reality and full automation of the procedure, allowing us to do what we're doing. I must state that in a mixed reality world, in which the things are in front of us, will help us change many of the things that we do today. So what are the challenges in moving forward? The challenges are that when we look at robotic accuracy, and we saw it very nicely also in the presentation before, the screws do not always end up where we want them to be. And in this study, they looked at K-wire placement, which allows us to actually see where we're going versus where we want it to be. And it looks here about excellent, where everything's exactly the same, a symmetrical deviation, an asymmetrical deviation in a malposition. We know that at least 10 to 15% of the screws have an asymmetrical deviation or in a very small rate of malposition, and that is because the skive and soft tissue and bone differences. Looking at the study again, excellence were in 81%, only in good, which was about 17%. In most cases, it's an acceptable variation, but we're still in the 88%. In asymmetrical variation, symmetrical deviations, we have a bigger problem, and definitely the malposition rate. Now, when we're looking at the way the companies present the data, everything that's in type 1 and type 2 will be considered as great outcome, and that's not always the case. So going into the sub-millimeter zone accuracy, we need to take off some active constraints. In today's robot, we created haptic boundaries that physically prevent the tool from entering the unsafe areas as nerves and vessels. We try to, when for planning, we're supposed to stop it. But in the future, when we're moving it down, we'll need to have the robots themselves do this for us. And in a way, integrate areas of no-fly zone, showing us where we're supposed to go in order to prevent it. If we're doing a large case of a corpectomy or going anteriorly and we know that we're close to the vessels, we need to make sure that the robots are going to allow us or prevent us of that fake barrier that our tools will not be able to go where we want to go. If we're going to drop between the 0.5 millimeter precision, which is better than our hands, because our hands can only usually work at a 1 millimeter precision, though that will allow us a level of accuracy that better than the human hand, and even which is seen today in the total knee and hip replacements. The Mako robot in the newer generation allows a 0.5 millimeter precision, and this will allow more precision alignment, significantly reduce implant wear and the need for revision surgery. In our spine world, we're aligning the screws. Hopefully, in the future, we'll have some studies talking about screw alignment and how to reduce not only the sagittal balance, but the intervertebral alignment, talking about how the implant should be placed and what density should we be putting in to prevent implant failure. Let me just show you guys a case of a 12-year-old girl that came to us with a tumor in scoliosis. She had a tumor surrounding her thoracic spine. You can see it's right at the apex of the scoliosis. This is a very big schwannoma, or I assume to be a schwannoma, which was causing her a lot of pain. And you can see that it's coming from the aorta all the way over in around the apex of the kyphosis. And when we discussed the surgery, our thoracosurgeon said, look, we don't need to do this as an open procedure anymore. We use our Da Vinci robot to do it. And we said, this is a growing child. At the time, she's a wrister too. And we said, you know, instead of fusing or doing a posterior-based surgery, if we're already exposing the surgery, we do VBTs in Hadassah. And we said, let's combine the two procedures. So you can see me on one side and Professor Orivald, the director of the thoracic surgery. And you can see the Da Vinci working here at a 10x level. Now, this allows us to have two extra joints that our hands do not have, and allows us, you can see in the upper bit, the tumor, and the lower bit, the hemiazygous vein, and the separation at a level that a human eye cannot do with that level. So we continued in that case to take the case on, and you can see the Da Vinci on the left side of the screen. On the right side, you can see the pedicle screw insertion being inserted into the spine. Still looked for the Da Vinci. I'm actually screwing it in because the Da Vinci is a soft tissue robot, but everything else is done with the Da Vinci preparation. This is the final outcome. You can see our 4 screws correcting the VBT, and the entire screw and the entire tumor out resected in one stage. The surgery took about 4 to 5 hours, and the patient went home on POD 3. As I mentioned beforehand, in the volumetric world, and if we take this road out of the joint replacement and move it into the spine, think about laminectomies, foraminotomies, think about removing bone spurs from different and tight spots where our hands cannot be. We can have those extra joints leading us down there with the optics that come with it. And all of that is coming down the road in the next future generation of robotics. We're talking about the precise decompression. We need to remove the bone or the disc correctly. Our goals are to minimize the risk of nerve and spinal cord damage and improve relief of the nerve decompression symptoms. Now, if we don't get a better decompression, we'll have a problem. And we all know that many times when a patient comes back to us with post-op residual pain, and we look at that MRI or the CT scan, we know that at times we're not that happy about the foramens, and we're looking for a better way to decompress them. In addition, this is a nice case out of a paper about talking about navigation for corpectomy. Wouldn't we love, when we're going into a cervical case of a corpectomy, to know exactly how deep we are? To have that submillimeter feeling when we're reaching that posterior cortical bone and we have the cord stuck underneath us in that nerve-wracking state where you're saying, okay, a little bit too much, we'll have either a duotomy or some cord injury, and a little bit less, we'll still be struggling against cortical bone and working harder. And this is where the next generation of robotics is going to take us. Now, spine motion during a case is a huge issue when we're allowing the robots to take a more autonomous pathway. And we know that we can always have a bad robot, which causes problem. And this is one of my cases from a week ago. This is a 45-year-old lady. And we've been through the learning curve, and I'm doing this case. She came in with a car accident, a very dramatic case where she was an 8-month-old pregnant, 8-month pregnant lady, and she had an emergency C-section. The baby was alive, and she had a spine instability. And what you can see here are 2 fluoro shots. I put the first screw in, everything looks good. Then I move on to the second screw. And as I'm coming down with the tube for the second, like I'm cutting the skin, I'm coming down, I feel a little bit of bone. And as I'm coming down with the working cannula in the fiducial, the denture probe, I feel that it feels soft to me. I don't feel the bone. And as I'm going down, it seems much deeper than I'm supposed to be. I stop the case. I did this with Gil, who's a guy in charge of the O-arm, and we said, let's re-register. And as you can see, between the first screw and the second screw, at a 10 to 15 degree twist, the fracture destabilized itself and moved between the first and after the first screw with a 10 degrees. And you can see on the picture of me standing next to it, you can actually see the difference. It's hard to see, it's a bit far away, of about 3-4 millimeters in the skin level of where the skin incision went to. This is critical because if you don't understand that the spine can move during the case, you're going to end up with screws where they're not supposed to be. And you might end up with a case where the screws are going through the canal and you have a big problem. This is still a problem with cases, and when we over rely on the robots and not understanding it, we can end up with cases that will cause a disastrous outcome. Now we got to remember, also as mentioned here before, that robotic technology is a highly delicate case. And many times you can still have a bad hair day in which you think everything's going fine and the robot's going to send you into a very bad trajectory. And you can ask them, what's going on here? And they'll say, we don't know. You'll go re-register. You won't work. And sometimes the technological bugs inside are still not worked out to that point. The next step of what the future is going to come is going to have a dynamic environment adaptation. We can consider this as the thinking robot. This dynamic robot will allow us the sensors that will lock onto the bone, not to the table. The robot will breathe with the patients. Now, if you think about the cases where the anesthesiologist is inhaling a little bit too much, the spine is growing and anti-growing. We'll need to have an anti-skiving control, making sure the tools end up where they're being. And the skive, which was mentioned here before, is a huge case of learning. And you have to learn how to feel with your tools if you're not doing it. We got to make sure we have a loop feedback that will prevent the slippage in a micro-millimeter adjustive level. And then we got to re-register as we're moving up. And here, optic cameras will allow us to do this as we're doing it because we cannot allow ourselves and our patients to keep on doing repeat O-arm spins as we're going on. The amount of radiation exposure to our patient, definitely in the pediatric world, is tremendous. Let's look at the cervical spine we mentioned here before in accuracy and inaccuracy, and look at the size of the pedicles. The cervical spine pedicles are quite small with 3 to 4 millimeters, and we know that there's a lot of motion going on there. Now think about a 3 millimeter shift in a cervical spine pedicle. If it just goes 2 to 3 degrees to one side or the other, we'll find ourselves in the vertebral artery or in one of the foramens. And that has to be thought of before, and we got to track it as things are moving around. Which one is spine surgery? Is it the open highways or a complex road with many, many streets going on? And it's clear that we're not yet at the point where the robots can deal with such a complex environment. Are we ready for that? So in summary, the future of spine surgery is quite intriguing. Robots are going to be more independent and capable. AI, which is coming and will allow them to make real-life decision-making during surgery. And surgeons will transition more to a supervisory role in making sure that the robots do what they want. We got to take this into consideration with the ethical considerations that not everyone is equal. And there's a high cost of robotic systems. Robotic systems need extensive surgeon training. There's concerns behind it about job displacements are coming in, and ethical questions about robot autonomy. If something goes wrong, should we sue Medtronic? Or is it our responsibility to make sure that our patients come out in the right thing? Who's gonna come out and talk to the patients? And the last question, which I would like to raise here, will robots replace the human touch in medicine? And I'll speak about it there. So which part are we? Are the part that we're arm wrestling with the robot or shaking hands with the robot? And I'd like to believe that we're shaking hands with the robot and they can enhance us in our next steps. You got to remember that you have to have a dedicated OR team. And in any hospital that's technology works, a team works as one. They don't work as one, it is useless altogether. Don't forget the cost involved, and we know that robotic surgery bring into institutions somewhere between $1 to $3 million. And this price is a huge investment for healthcare organizations, and that needs to be taken into account. I'd like to end by saying, using the old words of Hippocrates, saying that cure sometimes, treat often, and comfort always. And that is something that we as doctors got to remember. Then at the end of the day, we're taking care of people, which we're bringing them back to the families. And we've been blessed with the tools to help people, but we got to remember to not to use our human touch as we're treating it. And as we're trending more and more into robotic autonomy and the robots are continuing to move on, we got to remember our place. And I would like to thank you and please come to visit us here in Jerusalem at the Hadassah Medical Center. Thank you.
Thanks, sir. I think, Dr. Chabra, we have a few minutes for questions before we go down to the panel discussion. Did we have any questions in the chat box? Lima, have you seen any questions in the chat box?
Just a minute, sir. Not yet, sir. No, sir. No questions.
I will just start off with a very simple question that many of us who are into training institutes and we train fellows for spine surgery, would it be a good idea for these trainees to start off with a robotic pedicle screw insertion, or should they have a grill and open pedicle screw insertion before they go on into robotics?
Josh, would you want to respond to that?
Sure. Thank you. It's a great question. I mean, we're back and forth with that, and we train fellows, and I think they need to know both. And the question is, should they only know robotic spine surgery? The answer is no. They definitely need to have the ability to understand the anatomy, because if the robot doesn't make some mistake, they have to know how to fix it. If the robot's done, they can't just say abort the case, abort the case. So, but does it have to be on patients or on cadavers, on complex cases, on simple cases? I think as training doctors, our job is to choose that. And I would say, we have enough patients that have very big, easy pedicle insertions that we can train them on. And that's something that we got to train. And, if it comes down to the delicate 2 millimeter itsy bitsy pedicle, I would say, either to an advanced training level, and that's where technology comes in.
Thanks. Any other comments from speakers or Dr. Chandra?
Yeah, I would want to ask Dr. Schroeder. Dr. Schroeder, I think we all agree that robotic technology is still in its infancy. It's going to evolve substantially. And as AI and robotic technology explodes, right? Where do you think we are in tapping the potential of robotics percentage-wise? Are we there 50% or are we still in 10, 20%? It's going to, you've talked about some of the future advances that we are expecting, but a rough idea of how much are we going to go beyond what we are doing right now with robotics?
I think that we're going to move dramatically forward for two reasons. I mean, maybe three reasons even. First of all, patients are going to require it. And, the more data that's being published, that if we have a better outcome, people will want it. And I think that the next generation of the robotics, if it will save time and make us do more cases and safer cases with less complication, management is going to mandate that coming in. Now, what about, that's all of our robots out there today are just, pedicle screw inserters, good pedicle screw inserters. And when the robots are going to come in and allow us to do further steps in the surgery, decortication, and I'm not talking about a facet decortication, I'm talking about real decortication. and we have a 3-4 level decompression. And instead of working on it with an ultrasonic knife and an osteotome and a burr and a kerosene, and an hour in, your hands are hurting you and you're tired. You'll just press enter, 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 and you'll stand for 10 minutes aside and watch it do it for you. You'll be much more of an adaptation going on. And I think that's something that will definitely help us. And I think that in the cervical world, we're definitely in the infancy. And looking at that paper with corpectomy done with the robot, for real life surgeons, for that second where you're nervous, where you're very close to the cord, and you say, okay, this is everything up to now was a game. Now let's get down to the business of the 2 millimeter mistake. That would be tremendous for us as spine surgeons, knowing to have that assistant going on.
Thanks.
So can I ask a question, Chabra, to Dr. Schroeder?
Yeah, sure.
Dr. Schroeder, I'm Shankar Acharya. I'm working in a hospital in New Delhi. We don't have robot yet. I want to ask what you just spoke in your presentation about the now we have optical sensor which tracks tracker, and that tells you the orientation of the bones and where to put pedicle screws. But what you did mention about the electromagnetic and other things. So how fast and how quick is this technology going to take over?
I think that let's divide into optic and electromagnetic, and we can talk about two different cases going on here. I think that, in open cases, I think that optic tracking has a big advantage to it because it's like our eyes, There's no extra, you put up an optic piece above, it can constantly track the field, like in a deformity case, I don't know, even a open TLIF case, it can actually track you as you're going on. And that's for the easy, and I think it's just simple. No wires attached, line of sight, and that would be very similar to what we're doing today when we're doing our eyes, brain, hands considerations going on with a case. And that I think will be quickly adapted into the system and integrated. The electromagnetics actually require direct attachment to each one of the vertebral bodies. And that is something that is there. It's still a little bit cumbersome in the sense that you actually need to have wires attached. We all know that if you have the wires attached, you need to go to a box. The box needs to go outside of the table. That needs to be managed. And then when you're starting to decompress, you got to take those wires out because you've attached them to a part of the spinous process or to the lamina. I think that will also be sorted out, but it's a little bit more cumbersome and will take a bit longer. And in addition, the electromagnetic ones in completely MIS cases, this is also a problem of the optic ones. There's no way for us to attach to the vertebral body. There's no way to make sure that the rotation is going on. And that's a challenge which we have today. Because if you're doing this, like if you're doing it a complete MIS case for a trauma, for MIST, for anything like that, where you're not actually seeing the vertebral body, you have to take into assumption that whatever modality you've used, fluoro to CT, intraoperative CT, or rescanning, you will definitely end up with the same challenge as you had beforehand.
Thank you, Dr. Schroeder. Somajit and Shankar, with your permission, we'll move on with the panel discussion because many of the questions will get answered as we move ahead with the panel discussion. And we can take any remaining questions at the end, but would want to also acknowledge what Dr. Rupinder has mentioned in the chat box, the importance of training in open surgeries in addition to robotic surgery. So people, if for some reason technology fails and people have to move on to open surgery, they should be well trained in that regard. So take that very well, Rupinder. So we know that robotic technology in spine surgery has moved beyond novelty and early adoption. The key questions today are no longer whether robotics works, but for whom, when, and at what cost it truly adds value. This panel that we have brings together diverse perspectives to examine robotics as it is actually practiced across different case profiles, and we have them from Jerusalem to all parts of India, institutional settings and economic realities, particularly in the Indian healthcare ecosystem. The focus of the discussion would be evidence versus enthusiasm, incremental value versus incremental cost, and lessons learned from real world successes and failures. So, we would start with the first question, and I would request Dr. Josh Schroeder to respond to that. Who should adopt robotics and when?
So I think if you're asking me, anyone that's looking at to improve patient care and try to equal the level field. And that is pretty much, I would say, anyone in a big institution or anyone doing spine surgery. And it helps you, it makes your life easier, it makes everyone's surgery be equal, as mentioned very nicely by my colleagues beforehand. And I think if you have the ability, you should use robotics. When in the career, I would say that it would be great to have independence as a surgeon and then bring it on, but not too much independence um, because if we lose ability at this point to do things freehand, this is an ability that will be very, very difficult to gain back. And many times people think we can over rely on technology, but we all know that you still, like in a car, as I mentioned before, you still have to know to drive your car if the autonomous driving doesn't work during that day.
Thanks, Dr. Schroeder. So you very rightly mentioned big centers. So there is evidence that high volume centers and specialized surgeons, here the surgeons are more likely to integrate robotics into routine practice. And evidence from global surveys shows that robotic systems are more commonly adopted in higher income countries and by surgeons with high instrumentation volumes. Then surgeons focused on complex instrumentation. Early adopters often include surgeons focused on minimally invasive procedures where robotics can facilitate navigation and consistency of technique. Institutions with resources for training and technology. Early adopters are frequently academic centers or institutes with established robotics curricula. So, there's some evidence from the literature in this regard, and we'll come to this because we also need to justify ROI when we talk about adopting robotic technology. So, my next question would be to Dr. Puneet Girdhar. Dr. Puneet Girdhar is a prolific spine surgeon in one of the tertiary care centers in New Delhi, BLK Hospital. Puneet, which case profiles truly benefit from robotic surgery? I believe Puneet is there. Yeah, Puneet, you are muted. Please unmute yourself.
Yeah, hi. Good
Yeah,
evening, everyone. Am I audible now?
yeah, very much audible now.
Yeah. So, this question actually is loaded with two questions. Which case profiles truly benefit, and which case profiles should we select for doing robotic spine surgery? So, in my 3.5 years of robotic spine practice, I have practically a lot of degenerative spinal practice, and I have tried to apply initially to every degenerative case so that it becomes a part of your learning curve and it becomes an objective in your department, so that for your novice surgeons in the team as well as for your fellows, it becomes a routine practice and the expertise goes to the next level. While which case profiles truly benefit, I think I will enumerate it, but it has been a part of everybody's talk tonight. The foremost in my eyes which truly benefit are the revision cases, definitely, where either previously there is a prior instrumentation, or there's an adjacent segment, or there's a distorted anatomy for some reason. Those cases, in my opinion, can really benefit from robotic planning and execution. Number two, minimal invasive spinal surgery, I think, which is the foray in which my hospital spinal center works extensively, where it has the one foremost advantage of reducing radiation hazard. I think one of Vidya's slides was showing that he does like 100 kyphoplasties. Similarly, if you do like 1000 MIS spine surgeries in a year, it is going to be crazy radiation. There may not be an RCT today, but we understand it is unprecedented. Only the future will tell the amount of radiation that we can reduce with the help of a tool as useful as robotics in these cases. The some other cases where true benefit lies is a lot of deformity cases where complex deformity cases, but it comes with a caveat that if it is grotesque, it may not give you the trajectory what you want. But still, that's something in evolution. But I think Dr. Vidya per se in India has led this and has shown truly by innovating some new things around it that how deformity cases he can do very smoothly without any major complications, and has invented and innovated newer techniques there. Some other patients where this is of major advantages, like a complex anatomy like axial spine, C1, C2, or S2 alar iliac screws, or dysplastic pedicles. And last but not the least, I think patients who are obese, where imaging is an issue, quality of image as well as spinning your C arms around it, robotics can really give you an edge. And sometimes even in osteoporotic patients, if you want an optimal trajectory, then robotics have an extra edge over doing freehand. So the benefits are the case profiles where it is benefited I've enumerated as of now that occurs to my mind. But definitely it can be a game changer if you inculcate it into your routine practice, especially as we have mentioned many times in high volume MIS centers.
Thank you, Dr. Puneet Gardar. That was a wonderful overview of the case profiles where which truly benefit. In fact, evidence also mentions the same. Complex multi-level fusions or deformity, thoracolumbar instrumentation, AIS, minimally invasive spine surgery, revision or altered anatomy, and higher radiation exposure scenarios. This is well documented in the literature in this regard. So you have summarized it very well. Thank you very much. So we moved on to the next question. Is early adoption worth it, or is it better to wait? So we'll ask none other than Dr. Bharat Dave, who has been a prolific user of technology, to give his views in this regard.
Um, in my book, I think early adoption is important. It's
Can
noisy.
those not speaking kindly mute themselves? Can those not speaking kindly mute themselves?
ओम प्रकाश जी म्यूट कर लो.
Yeah, please go ahead, Bharat.
Sure, sir. So in my book, the early adoption is certainly worth it because it gives you everything. You have OM navigation, you have robotic, you have CM, and you have the workload where you have mix and match everything together, and you can train your individual surgeon as well and the fellow as well. So we are all ready with everything together. So yes, early adoption is certainly worth it, and it certainly gives you the different platform as well for the patient perspective. So you can give choice to the patient as well that this is what we have, and then let patient decide as well. Sometimes it gives the flexibility to describe and to give and get the best. And particularly when you have the complex cases which was mentioned earlier by yourself and in the previous talks as well. So that is why early adoption is certainly worth it.
Thank you, Dr. Bharat Dave. So there are pros of early adoption. Of course, we've been talking about accuracy and potential patient safety benefits, but long-term improvements with experience is also there, and future proofing and innovation, as Dr. George Schroeder talked about, is a pro of early adoption. Cons and limitations of early adoption may be high upfront costs and operation costs, steep learning curve, and risk of underutilization. And so, framing the early versus wait decision, we could say that high volume specialized surgeons and centers are best positioned to adopt early. and most of the faculty here are representatives from such centers. For others, a measured weight until cost decrease, training becomes standardized and broader outcome data matures is a defensible strategy. Adoption should be data driven, supported by institutional commitment, and aligned with goals rather than driven purely by new tech enthusiasm. So, the next question would be on capex versus long term return of investment, and we would want Dr. Vidyadhar, one of the most prolific users of robotic technology, to give his views in this regard. So the capex, as we know, is substantial versus long term return of investment. Dr. Vidyadhar, your views?
Thank you, sir. That's a very valid question for at least Indian users. I don't know about abroad, but in India, to give my own experience, I had visited Isidore Lieberman in 2012 as a part of SRS Traveling Fellowship, and I was very much inspired because I happened to watch him do the first ever robotic scoliosis surgery in the history, and we were all so excited. So I started asking for the robot from then on, and hospital only management had done their study because I was consistently asking it. And by mid 2016, they came up to me and said, Vidya, you have to do at least 100 cases a month to make it a viable option for a hospital of our magnitude. And that time I was doing nearly about 45 surgeries a month. And then we went on to do 100 cases. And the logic is very simple. It's a high value asset. And every hospital which purchases would want the return to come back in 3 to 5 years. They can't wait for 10 years for value addition. So if you are a hospital chain which is individual based, like say Dr. Bharat Dave, and I think you can afford to buy and do it as a value addition. But if you are working for somebody, for a corporate hospital, if you twist arms of the hospital management and buy it when your numbers are not matching to the number average return per patient per uh, money that has been invested by the hospital, I think you are asking for trouble, because very soon the management is going to come back to you and ask you where is the ROI coming. So it's very delicate to know when exactly one can demand. Rather, I would say definitely in India at least, definitely more than half of the patients would opt for robotics if given a choice, at least in a place like Bangalore. I'm sure it is the same case in Delhi. But there are multiple things like how the hospital negotiates the price, how the hospital negotiates the price of the consumables, how much of ROI return would cost the patient per case. So it's a multiple things in one package. So if you're adding, say, 1 lakh for a patient additional, robot makes it a worthy investment. If you're going to add 3 lakhs for a case, robot becomes too expensive, at least in Indian scenario. So I think it is dependent on the hospital, dependent on the owners or the investors, and the numbers that the surgeon gives the hospital, so that the return comes in 3 to 5 years. If you're not up to that, I think wait, hold on, and try to improve your practice before you demand. Because once you demand and the hospital budgets and it's on your head, and you will have to face the music in the near future when your return is not coming as per the expectations from the management. I think I would end with that. And long term, definitely it's a value addition. It's a institution which gets the name, fame, and you are having a state of the art infrastructure to do a spine surgery safely, as safe as it can be in today's world. Thank you.
I think Guru has
Thanks,
raised
Vidya.
his
I
hand.
think Dr. Guru Raj had a comment or a question. Guru, please.
Actually, sir, this is what I was. Vidyadhar has been very truthful, but then this is what I was mentioning in my talk, that when you invest upfront so much, like Dr. Bharat Dave, he has his own setup. Nobody is asking him questions, but then it becomes number game versus technology. So that's why we have to be very, very careful. Puneet is laughing. I can see that smile. So we have to be very careful when we uh, talk about technology and the money game. So it's that's why I said it's a very big unholy alliance. You talk about technology and ethics, it becomes really difficult.
But
Dr.
I
Swamiji?
should tell
Yeah.
Manipal definitely has a different take because they wouldn't buy, no matter how much arm twist I do, they wouldn't buy unless they find the value that, okay, I can
Very
deliver.
true. Very true. Swamijit?
I think a major important question which needs to be addressed in the Indian patients is that the insurance doesn't pay for this. And until unless in the future insurance pays for robotics, I think it will not take off as it is expected to take off in the next decade.
So,
Sir,
Secondly, the
actually,
hospitals, just I'll finish up.
sorry, sir.
Yeah.
For
So
insurance, I think there is a rider for advanced surgeries. So a lot of patients don't have that rider. That is the problem. Otherwise, insurance companies nowadays they are allowing robotic surgery.
Guru, I think that's not truly correct because at least in the eastern part of the country, most of the hospitals are sort of dictated by insurance companies rather than in the western sector part of the country where the hospitals dominate the insurance sector. In most of the parts of the country, we have insurance companies who do not pay for robots and insist that if you have to take money from patients for robotics, you have to do it as an OPD procedure rather than an inpatient billing system because the insurance doesn't allow for that billing also. And they never reimburse patients for robotics usage. Only in a very, very few insurance packages is additional advanced surgeries included, and in those small subset of patients, you can get paid by insurance, though not routinely. I think that's a very major stumbling block in the future. If robotics needs happens on a large scale basis in India, insurance companies will have to pay.
Uh, yeah, Swamiji, totally agree with you, and that's probably where the role of ASSI, professional societies like ASSI, and the enabling technology SIG of ASSI comes in. We need to lobby with the insurance, we need to lobby with the government, and we need to create awareness in this regard. If we believe that it adds value, right? So, see. There is an upfront investment, right? There is a high capital acquisition cost, annual maintenance cost, per case disposable cost, but uh, you have with it an ROI lever, reduced revision surgery, shortened length of stay, uh, improved OR efficiency with experience, surgeon longevity and safety, and enables complex and referral cases. So there is a lever, and this is well documented in the literature. So these all reduced revision surgery, shorter length of stay, operating room efficiency, and radiation reduction have been well documented. And evidence shows that there are phases when you adopt robotics. Phase 1, 0 to 2 years learning curve, longer OR times, training costs, and limited ROI. But as you move to phase 2 and phase 3, the ROI keeps increasing. So robotics is not instantly cost effective. ROI also depends on volume, case mix, and sustained utilization beyond the learning curve. And there are various myths which are prevalent also. For want of time, will not go into it, but robotics definitely augments the skill, and it patients generally look for robotics, as Vidya was also mentioning. So centers which have robotics, they will have better turnover, and it's definitely a useful tool. So coming to the next question, would ask Guru to talk about that. Guru, how can robotics be justified in the Indian healthcare ecosystem? Are there any different factors which come into play in the Indian healthcare system than in the Western healthcare system which could justify robotics?
Sir, frankly speaking, you know that we've been the one of the first adopters of the robots, and we had our own challenges. So I see it's very difficult to justify right now in Indian scenario the high cost for technology or equipment. But yes, we know that our cases are they present to us at the late stages. We have very like gross negligent deformities. We have gross negligent degenerative cases, and we do have, if at all we have revision cases, they are very, very bad. So in those scenarios, and especially in high volume centers, robotics certainly justifies its value. And especially in a developing scenario like MIS cases, like we everyone is talking about more lesser and lesser these days. And with my own experience, I can tell you robotics is a game changer for your MIS cases. But then all said and done, still robot has to justify itself in Indian market.
Yeah, this others are open to comment on it, but in India, most systems are import dependent, increasing the acquisition and service costs. So that adds to the challenge, right? Budget constraints, variable insurance coverage, and out-of-pocket payments amplify the scrutiny of return of investment. In India, robotics must justify itself not as a luxury, but as a strategic investment. But there are high ROI Indian use cases, like most of your centers uh, uh, high volume centers, tertiary referral centers, where you do deformity revision and multi level fusion practices. You do MIS heavy spine programs, and there can be various models which are available. In fact, we could get the industry also to offer models like pay per use or shared robotic models, which can help us in having a better ROI per se. Then you see, strategic or indirect return of investment is especially relevant to India, right? So the patient confidence would be more in institutions which have high technology like robotics, right? They would differentiate these institutions. And you know that there's a lot of medical tourism and complex case referrals which is taking place in India. And you can safely scale complex spine programs. So one may say that in India, high capex is a real barrier but not a prohibitor. If robotics is deployed in high volume, complex spine practices with evolving financial models like pay per use and shared platforms, and if efficiency gains reduce revisions and complications, then the system can achieve sustainable ROI. Data from cost effectiveness studies worldwide supports this potential, and the emerging Indian market shows growing adoption despite current insurance and training challenges. So we'll come to the next question, and no one better than Dr. Josh Schroeder to answer that. Dr. Josh Schroeder, what data is still missing and where should we prioritize? And we will talk separately about the Indian context also in this regard.
So I think the real life data is missing. I think actual surgeries, successes and failures, we're very good at showing our successes, and we like to cover failures, but we need to have honest discussions on limits and advancements. I think we need to have a registry with joint database and societal meetings on this topic and talking about different places and different challenges. I think we need to unify our training programs and have the industry that is selling the robot not only sell it to us, but make sure that the people are trained properly in the techniques that are needed in order to make sure everything's done safely. Make sure you don't start driving a car before you go through a learning school, and people think, oh, we can just take this on, and usually, and I think that these kinds of courses should be part of our day or of our practice. And once we gather the data on a large scale, then we can go back to the agency and say, look, this is the gaps. And every one of us can be the next step innovator. This is what we need next. This is where you're failing. And the larger number of N, the more accurate it is, and the more autonomous will allow these procedures to be.
Yeah, actually, you very nicely summarized, and we'll talk a bit about the Indian data. So, unfortunately, there are not many. Vidya has been publishing a lot, but no robust Indian studies on cost per avoided complication, cost per avoided revision, break-even timelines in Indian hospitals. So Western ROI models do not translate directly to India, right? So because of different length of stay, pricing and volumes. So current literature focuses heavily on screw accuracy and radiation reduction. And there is missing data on 5 to 10-year functional outcomes, adjacent segment disease, and implant longevity. So again, which subtypes truly benefit? Deformity, osteoporotic spine, or revision surgery? Current studies, as you know, often pool heterogeneous cases, so we don't have the exact case mix stratification. And as you talked about training and credentialing outcomes, almost no data linking structured training, simulation exposure, or credentialing to clinical outcomes. So there is a lot of data that we can accumulate, and that brings us to the next question. Registry versus RCT. What should professional societies like ASSI and especially the enabling technology SIG of ASSI prioritize? And here I would want to ask Guru Raj and then Dr. Bharat Dave to respond to this.
Bharat has had go away to manage function. Guru can respond.
Guru?
Sir, uh, basically, I think this is too early to have like RCTs uh, in robotic surgeries, basic because uh, I think we should right now concentrate on registries where we can accumulate data and then maybe present pros and cons. Then we might have to do RCTs in this subject.
Fine. Bharat, are you there? Would you want to add?
Yeah, sir. I think registry should be really formed like the enabling chapter we have formed. And I think that will certainly give us the data. And I think we should come across and we should really do something related to the jugaad that we do. And that is why, in the ASSI also, I was pushing for the publication from our own presenters as well. So that is something which will really give us the next level robotic use as well. Thanks, Dr. Shashabra.
Yeah. So there are various reviews which show that why a registry is the first step, right? Although direct causal impact is hard to prove, national registries are essential for benchmarking outcomes, tracking implants, and generating real-world evidence and hypotheses for future trials. Experience from the Indian Joint Registry and mature arthroplasty registries worldwide demonstrate that surgeon-led, mandatory, digitally integrated registries can identify underperforming implants and reduce revision burden. So there is ample data on that. Where RCTs fit in? Existing RCTs in robotic spine surgery are mostly single center, underpowered, and focused on accuracy rather than patient important outcomes with substantial heterogeneity and publication bias. So, if there are professional societies which go into RCTs, it will be most impactful if they are built on registry infrastructure, use standardized outcome sets, and randomize clearly defined indications rather than heterogeneous all comers. So, in the next 3 to 5 years, a national ASSI robotics and navigation registry with mandatory core variables is the highest yield investment. Nested or registry based RCTs where randomization happens within the registry platform can then efficiently answer focused causal questions at far lower cost and with much better generalizability. And you are all aware that Soumyajit was working hard towards improving the research infrastructure, and we were almost on the threshold of having robotic registry, but there were some hiccups, and I'm sure we will overcome them and will be soon able to pool the data in order to take it forward. Now, the next question then becomes, so there is so much of data everywhere, Josh also talked about, right? Can Indian data influence global practice? In other words, is it important to gather Indian data and how will it influence global practice? And I want Dr. Puneet Girdhar and then Vidya to give their thoughts on this.
Sir, I strongly believe that Indian data can largely influence global practice for various reasons. We are very unique in this country that we have robots in public hospitals. We have in All India Institute of Medical Sciences. We have in lots of private hospitals. I think most of the faculty member here are from private hospitals. We also have very high volume centers, and we also have high resource centers like corporate hospitals, and we have low resource like charitable hospitals, and robotics is being performed in various different setups. And we also need to understand that we have the most diversified population within this country. If we simply compare the kind of skeletal build you will get from north, like in Punjab or Haryana, and then compare it with something from northeast, where I think you will have something more like a Eastern population is small framed largely. So it's a very diverse population that we have, and the data can be of immense value coming out of our country. Another point which I wanted to mention when we were discussing the cost is that India can actually define the economics of this robotic practice. As we all understand, like where the world is headed today is economic power is going to define who turns the world around, rather than the military power now. So we in India are actually building economic models in every sector, and we have shown recently in the war sorry to mention that, in BrahMos and Akash, and like what all can we sell to the world. And we have forgotten to actually discuss one point about when we were mentioning the cost, which I mentioned during my MISAP talk in Ahmedabad, when I was asked to speak on visit worth the cost. And since I was an early user within this country, so I must say that we should also look like Da Vinci and like knee surgery models, especially some bit of similar things being built within the country, made in India models. So they will also define the future of robotics, and the data originating from here is going to help the world largely because we can build very economic models in large proportions and can publish them accordingly.
Thanks, Dr. Puneet. Very well summed up. Vidya, do you have anything to add upon that quickly?
So definitely, data is the new oil, and I think all of us know that India we have diverse practices, diverse setups, and I think the way we innovate and way we what Dr. Bharat Deve sir was telling, the jugaad of it, I think India has a lot of brains behind stretching limits and going beyond the boundaries, as long as it is safe for the patient and you know that you are an experienced surgeon going across that. I think we have enough leeway in the medical system and the patient trust on the doctors that we can go beyond trying new things. And definitely this will, in fact, invariably influence the global practice. Like simple thing was pinless robotics. Now I think many centers across the world are using Medtronic Mazor X with no pin. So it is just that we have done 700 cases we published, and I think it has changed a lot of surgeons' practices as far as my knowledge goes. But it is not to say that we can change everything that the global practices with Indian data, but definitely we can contribute to a large extent because we do have large volumes. Only thing is, I think like many of us agreed that if Indian systems come, the robotic systems, or if insurance approves, if the numbers increase, I think India will have more numbers than anywhere else in the world, and maybe we'll have data which has to be collected in a researchable format, retrievable format, auditable format, so that we can give it to the world for improving the healthcare. Thank you.
Also,
Thanks,
Dr.
Vidya.
Vidya, I
Yeah.
think the kind of work that you are doing in deformity, I think that's also very rare that the world can publish because we get very advanced cases within our country.
True,
So very
like
rightly
everything,
mentioned. Yeah.
yeah.
So, Indian patients, as you have mentioned, often present with different pathology spectra. Delayed presentation is also one challenge. Nutritional status and economic constraints. So, robust outcome data can test whether benefits and risks of robotics generalized beyond the high income settings where most of the data at present comes from. And to shape international guidelines, Indian data sets must have high data completeness. So that remains a challenge. Standardized outcome measures and transparent reporting aligned with global recommendations for research quality and transparency in robo-assisted surgery. So the quality of data needs to be focused on. So collaborative analysis between ASSI and established international registries could position Indian data as a key component of pooled individual patient data meta-analysis that inform indications, cost effectiveness thresholds and training standards worldwide. So I'd come to the last question, but quick situations quickly, if you have any situation where robotics failed expectations. Dr. Schroeder has talked about them, but if any of you would want to share this quickly, we are running out of time. Please go ahead. Yeah, Puneet.
Yeah. Sir, I want to understand this question. Is it failing the expectations of surgeons or failing the expectations of the patients or failing the expectations of the management?
So
This is
both.
a very
In
loaded
fact,
one.
if it fails the expectations of the surgeon, then it fails the expectations of the patient as well, right? It may be linked, but whichever way, Dr. Schroeder mentioned that many times. Robo technology doesn't mean that it can be perfect, right? You can never achieve perfection. It's a continuous ongoing process. So just wanted to put it across, but Dr. Schroeder has brought that out beautifully. If any of you had any, I must acknowledge that in our learning curve, we also faced similar situations, and it has been a learning process, right? Because before we could come to
The user base needs to be increased somehow.
yeah, Dr. Bharat Dave. So Bharat will join us, will give his take-home message later, but maybe Vidya?
I feel basically, I think we are all learning, and I think we have a long way to go. And if we Indians come together, have a registry as mentioned by Dr. Chabra sir and everyone, Dr. Basu and everyone, I think we'll have a long way to go to have uniformity of practice, protocolization of approach to robotics, and I think it will also lead way in future for development of Indian system wherein maybe at some point of time it will become like a CM being used for spine surgery, and that would be the dream come true for every spine surgeon in India who is interested in developing this as a specialty. Thank you.
Great. So Guru? Guru was about to board a flight, so he may not be there. So, well, friends, robotics is not a shortcut. It does not replace judgment, experience, or fundamentals, right? So that basics need to be followed. Value is context dependent. Robotics delivers value only when aligned with volume, case complexity, team readiness, and training structure. Evidence must be homegrown. India needs national registries, and that's where the role of our SIG comes in. Cost effectiveness data and outcome driven metrics. And I think with the support of Samyajit, we should be able to establish our SIG's registry so that we pull in data and subsequently are able to carry out RCTs. But mind you, we have a research project which is about to start and which will help us take it forward. So, as mentioned by Puneet and others, we have to get volumes. The user base has to increase. But I think it's not only one stakeholder. All stakeholders have to play a role in that regard. Whether it's us professionals in increasing awareness about the technology, about us in training people who can then take it further, about us in convincing our managers about that ROI is not only direct, it can be indirect also. It can lead to branding of the institution. It can bring you more cases. It can have various indirect effects. But there, the policy makers have also a role to play. The healthcare providers have a role to play. The media has a role to play, and the community also, by accepting what experienced hands have to tell them. Of course, this will come with time. Like knee replacement once was doubted and today has become a household exercise, easily acceptable. I'm sure robotics will show that way in the years to come. And as the potential evolves, we will see much more value add of robotics, and it will be adopted more easily. So thank you everyone. I would hand this over to Dr. Somyajit and Dr. Shankaracharya for the closing remarks.
Thank you, sir. I think we had an excellent discussion. We just overshot a bit of time, which I'm sure the next webinar we will be keeping much more to time. Thanking all the participants as well as all the faculty for this exciting discussion which we had in the last 2 hours. Thank you. Good night. Enjoy the rest of the day.
Thank you.
Thank you. Happy New Year to everyone.
Thank you.
Happy New Year. Happy New Year. Look forward to
Happy
seeing
New
you all next Saturday, same timings, and to carry this discussion further. And of course, a more interesting discussion on navigation versus robotics.
Thank you. Thank you, sir.
Thank you, everybody. Thank you.
Thank you. Thank you.
Good night.